Welcome to Unit 5. This is Chapter 4, and we're going to talk about pain in this chapter, how to assess and care for patients with pain. The priority concepts we're going to talk about in this chapter are, of course, comfort. That goes with dealing with pain and helping people to tolerate their pain and treating pain. The interrelated concepts in this chapter are going to be cognition and sensory perception as it relates to pain. All right, pain is the most common reason people seek medical care and take medications. It's a very universal experience, but also very personal and very complex. It's our body's way of telling us that something is wrong. We need to teach our patients not to ignore pain because it's the leading cause of disability, and it has some pretty major economic impacts in our patient population. Improper treatment of pain is a worldwide health problem. We have to start thinking about pain differently. We need to have some interprofessional collaboration about how we address pain. So this should include nurses, of course our pharmacists, because we're going to be giving some medications to help with pain, but they may have some ideas of some other things that might help with what's going on with the patient as well. We need to get our case managers involved, our primary health physicians, and maybe even PT to try to help our patients deal with their pain. From these interprofessional groups, you'll start to see some innovative ideas on how to treat pain that uses more resources than just medication. Let's talk about what pain is. Pain is an unpleasant sensory and emotional experience associated with an actual or even potential tissue damage. So whatever a person is experiencing exists whenever the person says it does. So pain is whatever the patient says it is. Self-report is always the most reliable indication of pain because the patient is the only one who can describe his or her experience. Pain is very complex and it takes different approaches to control it. There are two main categories of pain and by duration, okay? So you have acute pain, and that's your short-lived pain, and it results from sudden accidental trauma, surgery, sometimes even ischemia or acute inflammation. When an area of the body is ischemic, which just means without oxygen for whatever reason, it is painful. You're going to find that when you see myocardial infarctions, when you see infarctions in the gut, any place where oxygen doesn't get to those organs like it should. Okay, our other categorization of pain by duration is chronic or persistent pain, and it can last a person's lifetime. And we also have cancer pain and non-cancer pain, and both of those can be chronic type pains. We can categorize pain by how long it lasts. Acute pain. It usually acts as a warning sign. And many times with acute pain, you'll see a fight or flight response. You're going to see the increased vitals, sweating, dilated pupils, protection of the injured area, so guarding of the injured area. The patient will often be restless. They'll be drawing away from the painful stimuli. And if it's really bad pain, they'll have the inability to concentrate. They'll be apprehensive and just an overall varying degree of distress. Here's an example. A patient on telemetry with tachycardia. You go in and ask, "Are you doing okay?" And they answer, "Yes," 3 times. And then finally you say, are you hurting anywhere? And come to find out, this is a particular patient that I have. The IV was infiltrating and she was experiencing acute pain. But she didn't want to tell me because she thought it was something that was normal and that she just had to tolerate. Okay? Acute pain is usually temporary. It has a sudden onset and it's easily localized. So in other words, they'll be able to say it hurts right here. And so a sudden onset of new pain has to be assessed very quickly, especially chest pain or abdominal pain that's scored pretty high, like on a scale of 0 to 10, around your 7, 8, 9, 10 level. Any kind of abdominal pain like that definitely needs to be assessed quickly. Because pain is such a personal experience, however, you may not see these responses, okay? The body adapts really quickly. So the absence of physiological and behavioral responses does not mean the absence of pain. Okay? When the patient begins to heal and notices even a small decrease of pain, they're able to cope better because there's a light at the end of the tunnel. So surgery pain is a common acute pain that we as nurses deal with. And poorly managed post-op pain has absolutely no benefit for the patient at all. All right? So we have to control that post-op pain, and it's really important because it allows the patient to heal and it helps in their recovery controlling their pain. All right? The severity of early post-op pain may be a predictor of long-term pain. So patients with unrelieved post-op pain are at a high risk for chronic persistent post-surgical pain. So especially post-op, we need to get that pain under control and stay on top of it according to our physician's orders. Okay, chronic persistent pain. It lasts or recurs for an indefinite period, more than 3 months. It has a gradual onset. Character and quality often change over time, and it serves no biological purpose. So it can result in emotional, financial, relationship burdens, as well as depression and hopelessness. Okay? So once again, pain more than 3 months, gradual onset. It has no biologic purpose. That means it's no longer the body's warning system. I mean, we get it already. It's hurting, it's hurting, it's hurting. It keeps on hurting. Profoundly affects the people. So it can also not only cause hopelessness for the patient, but the family also, because it's very hard to see your loved one in such pain all the time. We probably, in this group, we probably won't see those physiological responses you see in acute pain because the body has adapted. Both acute and chronic pain are so individualized that each patient needs a plan of care to deal with their pain. Okay, 2 types of chronic pain. We have cancer pain and non-cancer pain. Cancer pain is usually very progressive. Pain in cancer is usually the result of tumor growth and nerve compression, or invasion of the tissue, and of course also the extremely painful condition of bone metastasis. And then you've got the acute pain that is induced during cancer treatment. You've got blood draws. You've got surgeries related to removal attempts of cancer. You've got the toxicities from chemotherapy and radiation treatment. Cancer patients all the way around have to deal with pain a lot. Okay? Chronic non-cancer pain, it's been a global health issue for people greater than 65 years old for a long time, and it continues to be. It's formally called chronic non-malignant pain. It usually involves the neck, the shoulders, and the lower back, and over half of veterans of recent wars have this condition, and it can cause depression and decreased sense of well-being. So let's think of some things that can cause chronic, non-cancerous pain. Diabetes comes to mind. What type of pain do we have in diabetes? Nerve pain, right? Rheumatoid arthritis can cause pain. Osteoarthritis, Crohn's disease. What type of pain do people with Crohn's disease complain of? Central to lower right region of the abdomen pain. And what causes their pain? It's the inflammation of the GI tract. Intestinal cystitis. What is that? That's chronic bladder pain. Somehow the nerves in the bladder that sense when the bladder is full and then tells you to go get all screwed up, and you feel like you have a UTI all the time, and that's called interstitial cystitis, and that's chronic bladder pain. All right, we talked about pain categorized by duration. Now let's talk about pain according to its underlying mechanism. Okay, nociceptive pain, that's the normal pain transmission mechanism. So something happens to you, let's say you bump your hand really hard, and it transmits pain like it's supposed to. Then we also have somatic pain. This is when pain receptors in tissues are activated. So this is your skin, your muscles, your skeleton, your joints, your connective tissue. That's one type of nociceptive pain, is somatic pain. Another type, well, let's keep on with somatic here for a second. It may be described as sharp, throbbing, dull, aching, cramping, and it's usually very localized. Like we talked about before, it hurts right here. So that's somatic nociceptive pain. This also can include visceral pain. Nociceptive pain can. Okay, so I think I'm being confusing here, so let me just clear it up. Nociceptive pain, there are two types, somatic pain, and now we're going to talk about visceral pain. And visceral pain is organ pain, or the lining of the body cavities. So you need to make sure that you quickly jot down right here 3 examples of each thing that might cause somatic pain and 3 examples that might cause visceral pain. And I'll be expecting to see those in your Med-Surg notebook. All right. So we have the nociceptive pain, which is somatic or visceral. And then we also have neuropathic pain. Neuropathic pain is driven by damage to the peripheral nervous system or central nervous system. So neuropathic pain is the abnormal processing of stimuli. Nociceptive pain occurs in the presence of damage or inflammation. Neuropathic pain can occur in the absence of either. It'll be described as burning, shooting, tingling, feeling pins and needles. An example might be sciatic pain and diabetic neuropathy. Okay? So to recap right there, we have nociceptive pain, which can be somatic or visceral. Somatic pain is skin, muscles, skeleton, joints, connective tissue. Visceral pain is organ pain. Then we have neuropathic pain, which is nerve pain, like you would have in sciatic nerve damage or diabetic neuropathy. All right, pain transmission. Painful stimuli often originates in the extremities, and if it's not transmitted to the brain, the person doesn't feel any pain. There are 2 specific fibers that transmit peripheral pain. They're A delta fibers and C fibers. And just know that there's a pain cycle of transmission, and a break in the transmission at any point causes a change in the perception of pain. So I want you to read and be familiar with transduction, transmission, perception, and modulation of pain. Read those in your book and be familiar with those. All right, assessment. That's when we're noticing things about pain. So self-report is the gold standard for assessment of pain. So pain is whatever the patient says it is. We've said that before. The nurse's role is to accept the patient's self-reporting. You need to serve as an advocate for the patient, act promptly to relieve pain, and respect patient values and preferences. Okay? Location. That's exactly what it sounds like. You may need to use a body diagram for the patient to mark on. If they hurt all over, ask them to identify where they don't hurt, and maybe that'll help localize it a little bit. All right, intensity. This is where you have them rate their pain. This is your numeric pain scale. Of course, you go 0 to 10, with 0 being no pain and 10 being the worst they've ever had. You can also use the Wong-Baker faces. This is a self-reporting mechanism, not something you try to match their faces to, okay? If they're unable to choose a face, this is not the pain scale you should use, okay? Faces pain scale is for self-reporting of pain. You also have the Faces Pain Scale revised. You have the verbal descriptor scale. This is where you have the patient choose from words to rate pain. Example, do you have no pain, mild pain, moderate pain, severe pain, very severe pain, the worst possible pain I've ever had? That's the verbal descriptor scale. Quality. This is where you ask how the pain feels. Try not to give them hints, okay? They'll use words, their own words, like sharp, dull, aching, etc. You're going to need to know the onset of duration. When did it start? Is it constant or is it intermittent? What aggravates it? What relieves it? What makes it worse and what makes it better? The effects of the pain. How does it affect your sleep? How does it affect your activities of daily living? Comfort function outcomes. Tell the patient your expectations and what they need to be able to do, and ask them what is a pain level that will allow them to do these things. Example, after surgery, when do you think you would be able to walk? At what pain level do you think you would be able to walk? We always have to consider the patient's culture and past pain experiences, and also comorbidities, because they could be having some pain from several different areas. Psychosocial assessment in acute pain. Acute pain may trigger fear and uncertainty in some individuals, whereas others may feel that the pain is necessary and expected with what is going on. And after surgery to fix a problem, it may somewhat be welcomed because they know a problem they had been worrying about is relieved. All right? So in the nonverbal patient, you have to use some sort of checklist to assess their pain. Maybe the Faces revised pain scale, but you always also check vital signs. Always, always. Okay? That's in your nonverbal patient. In chronic pain, psychosocial, which means just relating to the interrelation of social factors and individual thought and behavior. So their psychosocial aspect may be affected. They may be scared, they may feel powerless, they may be mad, they may even be hostile or even desperate. And remember, we've talked about before that we need to assess the family as well. Maybe they have some kind of pain conflict with their spouse or caregiver. So I always think about one of my nursing instructors telling me about a lady that came in labor, and her husband just absolutely refused to let her have any pain medication because he thought she ought to be able to just tough it out. Well, every time the husband would slip out, the nurse would slip in and say, Miss So-and-so, I think it's probably time for your pain medicine. What do you think? Are you having pain? And when she said she was having pain, she would give her a little pain medicine. So we do have to kind of explore and assess the family as well and what they think about pain, but remember that your patient dictates what their pain is. The pain is whatever the patient says it is, not what the patient's spouse or caregiver thinks or says it is. Some people react to pain with withdrawal, preoccupation, depression, and sometimes physical symptoms. And I just always think about myself and how I react to pain. Acute pain, if something happens to me acutely that causes pain, maybe I burn my finger or stub my toe or whatever, my first response to pain is immediate nausea. So everybody kind of, um, responds to pain differently. Okay, the hierarchy of pain measures lists several strategies to use when assessing pain in the cognitively challenged patient. So be sure and read over Table 4-5 on page 53 and be familiar with these techniques. So one of the oddest symptoms of pain that I've ever seen is a crazy big smile with tears in their eyes. Facial expressions you might see are grimacing or crying. So some people may scream, and remember we're talking about the cognitively challenged here. They may scream or repeat a word over and over. I knew a lady in the nursing home that would roll down the hall, and when she was in pain, she would say, tell, 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 tell. Tell, 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 tell. So it's just a matter of knowing your patients. Sometimes they become restless. If they have some kind of change in their normal patterns, you might consider that it might be pain. If they're more confused than usual, your UAP may report to you they're just not right, something's wrong. If their breathing becomes more rapid, look at their body language. If they're crying and you're unable to console them, maybe it's pain that they just cannot verbally express to you. In ventilator patients, it's important to be able to set up a line of communication with the patient. Reading lips, communication boards, computer, picture boards, etc. Patients who cannot self-report are at high risk for undertreated pain. And the best scale to use for the cognitively challenged is the FACES Pain Scale Revised. Remember, it's the one that you can look at and compare it to their face to see what level of pain they are in. Just the regular FACES Pain Scale is a self-reporting scale, but the FACES Pain Scale Revised is not. Each patient having pain must have an individualized plan of treatment for that pain. All right? The plan must clarify the desired outcomes of treatment. Discussing options with the patient family and reevaluating the plan as time progresses are important parts of the plan. They may no longer need pain meds, or in a progressive disease process, pain meds may need to be increased as time goes by. A trend as of late is for a push toward multimodal pain medications, and that basically means using a combo of medications that act to alleviate pain in different ways. So you may have a mix of analgesics, anticonvulsants, and antidepressants, and local anesthetics that they kind of come at the pain from different directions. This allows for lower doses of each med, so you have fewer side effects, and it can often lead to greater pain relief. My mom just yesterday had surgery on her knee, and they put a nerve block in that's long lasting. And although the numbness that it has caused in her leg is driving her nuts, it's much better than the pain. And so that's one of the multimodal things that her physician prescribed so that she will not have to take so much pain medication at home. My mom is elderly, and we do know that taking pain medication increases your risk for falls. She's a very active person, and I would hate for her to get down because she had a fall after taking some pain medication that was actually needed. Okay? So multimodal treatment can reduce the incidences of prolonged post-surgical pain, and it also plays a part in alleviating persistent pain that's chronic as well. Although it's popular right now, the multimodal approach is, pain is complex and it takes different approaches to control it. And the multimodal way of approaching it may not be good for everyone, but in general it's a very good way to approach and not have to use so much of one type of medication. There are multiple routes and ways to administer pain medication. What is the preferred route of analgesic administration? Can you guess? It's oral. Why? Why do you think? It's because it's less expensive, it's best tolerated, it's easiest to administer, and you can give it at home for a good continuum of care from the hospital into the home setting. So unless you're NPO for some reason or just in excruciating the pain, the goal will be to move to oral medications as soon as possible. Around-the-clock dosing of pain meds is really helpful too. Why would we do that? Why would you just do it on schedule for a while, maybe after surgery? It's for pain prevention and to maintain pain control that allows the patient to function. And this is true for acute and chronic pain. If you have a patient that reports being in pain for 12 out of 24 hours out of 24 hours a day, around-the-clock dosing should be considered until the pain is well controlled, and then you might be able to go to more of a PRN dosing. PCA pumps, they're to manage all types of pain, okay? And that's pain control analgesic. These medications that are in a PCA have to be double-checked by 2 RNs. And this is the most important safety measure you can do when starting these meds. They can be administered IV. You can do some of the medications subcutaneous around the area that's causing pain. You can do it in an epidural, and you can do perineural or around the nerve or a bundle of nerve fibers. You're going to have a pump and a patient-controlled actuation mechanism, or a button for the patient to control. Some people who have PCAs require a basal rate and a PCA dose. A basal rate is just a continuous low dose of the medication, and then they can push their button to get a patient-controlled dose as well. And that's what PCA stands for. I'm not sure what I said a while ago, but patient-controlled analgesic. Basal rates are really common with epidurals especially. Primary benefit, only the patient knows how much analgesic will relieve his or her pain, so pushing the button is a good way to control pain. And we have to be sure and teach the family absolutely not to push the button. You don't push the button, they don't push the button, only the patient pushes the button. If the patient is not aware enough to push the button, then it's not time for pain medication. Keep that in mind. Let's talk about analgesic groups or pain med groups. The first group is non-opioid analgesics. Okay? That's your acetaminophen and NSAIDs. Acetaminophen, which is Tylenol. There are 4 things to remember about Tylenol for the NCLEX, for my test, and for nursing life in general. Number 1, it's for pain and fever, but does absolutely nothing for inflammation. Okay? Number 2, it can kill your liver. You have to watch for signs and symptoms of hepatotoxicity or liver toxicity. So what are some of the signs of being toxic, liver toxic? Yellow skin or eyes, pain in the abdomen, nausea and vomiting, loss of appetite. You're going to be fatigued, excessive sweating, have dark urine, pale skin, unusual bruising, and unusual bleeding. Okay? Number 3 to remember about acetaminophen. The maximum dose of acetaminophen is 4,000 milligrams per day. You have to calculate all sources, every mixed drugs. For example, Percocet. It contains varying amounts of oxycodone depending on what is ordered, but each tablet contains 325 milligrams of acetaminophen. And remember, for long-term use of the medication, especially in older adults, you need to decrease that dose to 2,500 to 3,000 milligrams per day. All right? NSAIDs. What does NSAIDs stand for? Non-steroidal anti-inflammatory drugs. Okay, these are your ibuprofen, Motrin, naproxen, Celebrex, ketorolac or Toradol. They produce pain relief by blocking prostaglandins through inhibiting the enzyme COX or I don't even want to try to say it. They are COX inhibitors, okay, or anti-prostaglandins. Make sure, let's see here. Monitor your patients taking acetaminophen for hepatotoxicity, and reduced daily dose may be appropriate for older adults. We talked about that already. Okay. So let's talk about prostaglandins or antiprostaglandins. And prostaglandins and what they are and when it's appropriate to use an antiprostaglandin and when it's not. Okay, so prostaglandins are lipids or fats that the body makes that act as a hormone. All right? Prostaglandins are made at the site of injury or illness, and they control processes such as inflammation, blood flow to the area, the formation of blood clots, and also the induction of labor. Okay? So almost any type of cell can make prostaglandins. So you get cut on your arm, prostaglandins are produced. You get an infection in your lungs, prostaglandins are produced. They're made at the site of tissue damage or infection. They cause inflammation, pain, and fever as part of the healing process, okay? So when a vessel is injured, a prostaglandin called thromboxane stimulates the formation of blood clots to try to prevent blood loss and contracts the blood vessels in the area, causing the vessel to narrow. Another prostaglandin called prostacyclin has the opposite effect, reducing blood clotting and removing any clots that are no longer needed and dilating the vessels. So the opposing forces of these two prostaglandins cause contraction and relaxation of the muscles in the guts and the airways. Prostaglandins are also involved in ovulation, the menstrual cycle, and the induction of labor. So each organ has different prostaglandin receptors, which allows the different actions of each prostaglandin to be carried out. They only carry out their actions in the immediate vicinity of where they are produced, and this helps to regulate or limit their action. So you can see that a drug that blocks prostaglandin production, like ibuprofen, could be good for pain and inflammation and menstrual cramping, because prostaglandins are what cause the cramping. So if you take an antiprostaglandins, it helps the cramping. Any kind of injury or disease that causes inflammation, like arthritis. So let's talk about who should not take antiprostaglandins like ibuprofen or ketorolac, Toradol, and why. Cardiovascular patients should not take NSAIDs, but almost all cardiovascular patients are recommended to take an aspirin, which is an NSAID. Why? Remember, we said that the prostaglandin thromboxane stimulates the formation of blood clots, and prostacyclin has the opposite effect by reducing blood clots? Well, aspirin works to block thromboxane, effectively blocking blood clotting effects of that particular prostaglandin. But ibuprofen tends to work the opposite, increasing risk of clots, and in particular clots in the heart and MIs in patients that already have heart disease. So antiprostaglandins should be avoided in patients that already have heart disease. Okay. NSAIDs can also cause increased blood pressure by blocking prostaglandins that relax vessels in the body. Prostaglandins also increase renal blood flow and glomerular filtration, so taking an antiprostaglandin like ibuprofen can decrease renal function and make you retain fluids. So if you are doing a medication reconciliation form when you admit a patient to the hospital and they're complaining of kind of this weird swelling that they've had for a while, and you notice that they take ibuprofen on a daily basis, this antiprostaglandin may be the reason, could be the reason that they are swelling. Asthmatics have to take NSAIDs with caution as well because it can block smooth muscle relaxation, and so it kind of promotes that wheezing and bronchial spasms that asthmatics can have. In pregnant women, NSAIDs can cause premature closure of the patent ductus arteriosus, and this is the fetal. It can also cause fetal renal impairment and pulmonary hypertension. It can delay the onset of labor, and it can increase bleeding tendency in the mother and the child. It can also interfere with ovulation. So those having difficulty getting pregnant should avoid taking it. Pregnant women should never take it. NSAIDs can lead to peptic ulcers with long-term use because it blocks the production of mucus that lines the stomach, which is our natural protector from our own stomach acid. So those requiring long-term use of NSAIDs need to also be on a proton pump inhibitor like Protonix, omeprazole, such as Prilosec, which is Prilosec, to decrease the production of acid in the stomach. All these meds, generic names, end in azole, so they need to be on azole medicine of some kind. Occasional ibuprofen in these groups might be okay, but long-term use should be avoided. Pregnant women should never take it. So let's recap right quick. Avoid NSAIDs in cardiovascular patients to control pain because it increases the risk of clots, except for aspirin. Avoid it in renal patients because it decreases renal function, causes swelling, and if they do have to take it, you need to be monitoring their BUN and creatinine. You want to avoid it in asthmatics because it may block smooth muscle relaxation and cause them more trouble with wheezing and bronchospasm. You also want to avoid it to control pain in pregnant women because it can cause premature closure of the vessels in the fetus that help it get its oxygenation. It also can cause pulmonary and renal problems, and in the mother it can delay labor and increased her bleeding risk. So those 4 groups, avoid NSAIDs to control pain. So we've talked about 3 types of analgesics by classifications. We've covered non-opioid analgesics, which are Tylenol and NSAIDs. Our second type to discuss is opioids. So what are opioids? Opioid drugs work by binding to opioid receptors in the brain, the spinal cord, and other areas of the body. they reduce the sending of the pain message to the brain. Remember how we talked about if you hurt your finger but the message doesn't send to the brain, you don't feel the pain? Well, opioids reduce the sending of that message. They're used to treat moderate to severe pain that may not respond well to other pain medications. So there are 3 different classifications of opioids. We have mu agonist or morphine-like agonist, and this is a substance which initiates a physiological response when combined with a receptor. Agonists are always trying to get a response going. Think of someone picking a fight. That's what an agonist is. They're trying to get something going. In this case, it would be more like begging for a back rub, okay? So, mu agonists, they work by blocking the neurotransmitter substance P, which prevents the opening of calcium channels and thus the transmission of pain. So it blocks that pain from going from wherever you're hurting to the brain. There are no ceiling in mu agonist, which means increased dose equals increased pain relief. All right? That makes them really good for a first-line opioid treatment of nociceptive pain that is moderate to severe. These are your drugs like morphine, fentanyl, hydromorphone, which is Dilaudid, oxycodone, which is Percocet or OxyContin, hydrocodone, which is your Lortab, Norcos, oxymorphone, Opana. Okay? So if a patient is allergic to morphine, the next best choice is hydromorphone, which is Dilaudid. They are both mu agonist, and they're really good for moderate to severe pain. Okay, mixed agonist. Mixed agonists bind at different sites to decrease pain. So they bind the kappa opioid receptors, they bind there, and they also bind at the mu opioid receptors as an antagonist. That's a substance that interferes with or inhibits the physiological action of another substance. So this is what the takeaway is from this. Anyone that has been taking a mu opioid for pain will have those mu receptor sites immediately blocked. So this can cause severe pain and opioid withdrawal, rhinitis, abdominal cramping, nausea, agitation, and restlessness. Okay? So if you're going to give one of these medications and a patient is already on a mu agonist like morphine or fentanyl or Dilaudid, the effects of that medicine that you just gave them is going to be blocked immediately. So these are drugs like Stadol and Nubain. All right? So these drugs also have a dose ceiling, so increased dose is not going to help increase pain relief. They're sometimes used in small doses to try and decrease side effects of the mu agonist. So those patients have to be monitored really frequently for pain control because there is a possibility that Stadol and Nubain or butorphanol and nalbuphine can block the mu agonist. Okay? Partial agonist, they're a little kappa and a little mu. They produce an analgesia plateau, so it's not easily reversed. All right, so you have to be really careful about these. The buprenorphine, or the Butrans, Suboxone is a familiar one for me. It's a combination of buprenorphine and naloxone, which works to reduce cravings of addiction. So be careful of those because they're not easily reversed. Now let's say, what is the reversal agent for opioids? It's naloxone or Narcan. Okay? So naltrexone is also another one that you may not be as familiar with, but naloxone and naltrexone both are reversal agents for opioids. It works by competing with those opioid receptors, but remember, as naloxone goes away, if there's still opioid in the system, more naloxone will be needed. And actually, it's been my experience that I've never actually seen only one dose given. If you give it in the field, you know, now they're making naloxone that can be given out in the public. If you give it in the field and the patient comes around, they are still in danger. They have to go to the hospital. They will probably need another dose and maybe a couple more before all of that opioids out of their system. Key principles of opioid administration. Appropriate opioid analgesic. So we need to know the type of pain, the intensity, the age, gender, coexisting disease, current drug regimen, potential drug interactions, prior treatment outcomes, and the patient's preference. Okay? Titration means that we're going to use the smallest dose that relieves pain and produces the fewest side effects. So when we think of titration, we often think about titrating down, but in cancer patients, they may actually need to be titrated up. So titration just means adjusting the dose up or down to take care of the pain, the minimum dose needed. We have to carefully assess our older adults to avoid undertreating pain. They're the ones that are not going to report it to you. The POSS scale, P-O-S-S. This is the Pacero Opioid-Induced Sedation Scale. And basically what it is for is to assess your patient before giving pain medications to make sure that they're not too sedated to receive the pain medication. Okay? So a lot of times facilities will require that you do a POSS scale as a safety measure to make sure that we don't oversedate our patients. So if you rate it an S, that means they're asleep, but they're easy to arouse, okay? So it's acceptable to give the pain medication. If you rate a 1, they're awake and alert, it's acceptable to give the pain medication. A 2, they're slightly drowsy, but they're easily aroused, it's acceptable, okay? So if you do a 3 or a 4 on the POSS scale, a 3 is they're frequently drowsy, arousable, but they drift off to sleep during your conversation, then it's not acceptable. We need to monitor their respiratory status and sedation level closely until their sedation level is stable at a less than a 3. Okay? We might need to actually decrease their opioid medications in people that are continuously being rated at a 3. If you rate your patient 4 on the POSS scale, that means they're somnolent. There's minimal or no response to verbal and physical stimulation. You're shaking them, they're not waking up. Okay, this is totally unacceptable. You need to stop all opioid administration and consider giving naloxone. All right, we need to stay with the patient. We need to stimulate them, make sure they're breathing okay. We're going to call a rapid response, call their primary physician or the anesthesia provider, and make sure that we take good care of them until we get this reversed, because this is a dangerous situation for them. And their pain assessment, their pain administration will have to be evaluated by the physician and changed at this point. Okay, we've been going through these PowerPoints for a little while now. It's time that you really need to take a break. Get up, walk around, go get you a snack, whatever you need to do. There's not an assignment for this PowerPoint video. After you take your break, go ahead and go and start on the second video for this unit. It will also be posted in Brightspace.